So, sorry about that interruption earlier. It was a little man coming home. Um, that was the weird noise. He sounded like a turkey outside. So he's on his way to bed, so we're going to be extra quiet. So anti-lipemic agents is a fancy word for cholesterol medications. Why do we care about cholesterol? Cholesterol can lead, as it builds up, it forms plaques within arteries, and it can lead to hardening of the arteries, arterial blockage, blood clots, as parts of it break off, heart attack, or stroke, and it may even play a role in dementia. That's something they're still working on right now. So there's good cholesterol and bad. I'm sure you guys have heard of LDL being your bad cholesterol. The higher the number, the worse it is. Try to get it below 100. HDL is the good cholesterol, and we want that. I believe it's above 50 for women and above 40 for men. I might be a little off on that. That changes every now and then, but the higher that number, the better. So how do we treat high cholesterol? And sometimes it's from diet. You can change your diet and your cholesterol will get better. Sometimes it's hereditary. It's a genetic part of our lives where no matter what we do, we're going to have high cholesterol. So statins are the primary first-line agent for hypercholesterolemia or high lipids, high cholesterol, whatever you want to call it. HMG, CoA reductase inhibitors, inhibit the enzyme responsible for cholesterol synthesis. So if we inhibit that enzyme, no cholesterol is made. These are the most potent agents out there for lowering LDL and increasing HDL. They can also reduce triglycerides, which is another component of cholesterol that can be harmful. HMG is most active at night, so it's usually given before bedtime. And out of those, they all end in statin, so that's why this class is called statins. Sorry, my dog's running around now. So side effects can include mild GI disturbances, muscle pain and weakness, and as well as something very serious called rhabdomyolysis, which is a destruction of the muscle tissues that can lead to renal failure. So we keep an eye on that with patients. We monitor their liver enzymes. We ask them to report any pain, muscle pain that they're having. You can try other statins when they have muscle pain. However, once they've tried a few, if it keeps happening, we do try to find other options for them. Bile acid sequestrants, exactly what it sounds like, sequestering bile acid to keep it in the intestine, and therefore interrupting the process by which bile acid is returned to the liver for reuse. When LDL is only moderately elevated, these can be used by themselves. However, it can also be used as add-on therapy. Let's see. Side effects include constipation, gas, cramps, anything to do with the GI system since they're keeping bile acid within that tract. Nicotinic acid reduces the hepatic synthesis of triglycerides and inhibits the mobilization of free fatty acids from peripheral tissues. So it lowers total and LDL cholesterol as well as triglycerides and raises HDL. All good things. Side effects of niacin can include GI upset, dyspepsia, blurred vision, and fatigue, skin flushing, especially with immediate release formulations, glucose intolerance and hyperuricemia, as well as liver damage, especially with sustained release products. Fibric acid derivatives, fenofibrate, gemfibrozil, they really don't lower LDL, but they're especially effective for patients with high triglyceride levels. And elevated triglyceride levels are bad because it can lead to pancreatitis. So they also improve glucose tolerance, so they're often used in diabetics, sort of as a double whammy. Treat triglycerides, lower them, as well as improve glucose tolerance. They're generally well tolerated, and the only side effects are GI related usually, possibly gallstones in the bladder as well. Cholesterol absorption inhibitors. There's only one. It's called ezetimibe, and it moderately reduces LDL levels by inhibiting intestinal absorption of both dietary and biliary cholesterol and blocking its transport in the small intestine. These are usually add-on therapy for statins. You see them used together pretty often. Last but not least, fish oil, omega-3 fatty acids. Usually used for reducing triglycerides. It also has a possible role in the prevention of primary and secondary heart disease. The best source is fatty fish, but fish oil capsules may be used as well. And usually the only side effects are a fishy aftertaste, kind of gross. Antithrombotic agents, basically meaning we are preventing a clot. There's anticoagulants and antiplatelets. Anticoagulants prevent the formation of a fibrin clot by interfering with one of the steps leading to fibrin formation. There is warfarin or injectable heparin compounds. Their actions are different, however, their purpose is the same. So we would use it to prevent or treat venous thrombosis, stroke, pulmonary embolism, and or coronary artery occlusion. Usually the side effect with these medications is the exact opposite of what we're trying to prevent. The side effect is bleeding, so we always keep an eye out for possibility of bleeding whenever somebody's being treated with these medications. Warfarin is administered orally. You hardly ever see it used as it says it is available as an injectable preparation. I've actually never seen it used that way. It has an antidote, which is vitamin K, because it interferes with the action of vitamin K. So if we want to reverse warfarin, we administer vitamin K. It can also be monitored by a lab value, which is good, called INR, so we can see how we're doing, how responsive the patient is to the therapy. Warfarin has a ton of drug interactions, most of which just raise the INR. They make warfarin more effective. Not too many side effects, really, except for that bleeding risk, so we keep an eye on that. New oral anticoagulants. There are several available now: dabigatran, edoxaban, and apixaban, as well as rivaroxaban. So these are all direct thrombin inhibitors, factor Xa inhibitors. Somewhere in the clotting cascade they fit in and they prevent something from happening. They have a rapid onset as opposed to warfarin, which acts a little slower, fewer food and drug interactions, but they really cannot be monitored with standard laboratory testing. There's also no reversal agent for them, so that's a little scary. There is an indirect reversal agent, but it's hospital only and sort of expensive. They are used to treat patients with atrial fibrillation, reduce the risk of stroke and systemic embolism. In that case, they can also be used to prevent thromboembolism from hip or knee replacement surgeries. Heparin and low molecular weight compounds. There are two types of heparin, unfractionated and low molecular weight. Unfractionated is the type that you see for infusion or subcutaneous use, whereas low molecular weight is usually just a subcutaneous injection. Cannot be given orally because it's not well absorbed from the GI tract, so that's why we inject it. Again, the only serious complication really is bleeding, drop in platelets, and there is an antidote for heparin, which is protamine sulfate. So, no agent fully reverses the activity of the low molecular weight heparins. Protamine has some activity and can be given for life-threatening bleeds. However, it's not as effective as it is for heparin. Side effects of all anticoagulants include major hemorrhage, thrombocytopenia, minor bleeding, blood in the urine, and osteoporosis with long-term use. Platelet inhibitor therapy, or antiplatelets. Antiplatelet agents inhibit the aggregation and release of thromboplastin from the platelets to begin the clotting process. They are used to treat patients who have had a recent stroke, heart attack, or established peripheral vascular disease. They are also used in the management of acute coronary syndrome, as well as for patients undergoing PCI after a heart attack. I'm going to let you guys read through this because, again, this video is going on towards 20 or 30 minutes. So the rest of the chapter is on your own. It's only a page. It's not too much more to cover. However, just go over the side effects, get familiar with the purpose of the agents. They're not used as often. Thrombolytics are only used in the case when a patient is having pulmonary embolism or ischemic stroke, and hematopoietic agents, or agents to create red blood cells, are only used when a patient has low red blood cells. So that covers our chapter 25. Sorry for the interruptions earlier, and I'll see you guys in chapter 26.